This conference will now be recorded.
This is John Antonucci, and this is the high-risk recurrent metastatic AnCan prostate cancer support and discussion group for September 24th, 2024. We want to start by acknowledging the support that we're getting from Bayer, J&J, Myriad Genetics, Telix, Blue Earth Diagnostics, Foundation Medicine, and Novartis. We make no demands on us, support us, and we are nevertheless going to try to give whatever experience we have impartially. We want to caution you that we do our best not to give medical advice, and all decisions will be made between you and your treatment team, but we'll share with you everything we know about your question as best we can. Now, I have three new guys tonight, and what we do for you guys who are willing is spend some extra time getting your history and learning about you. And if you're uncomfortable with that and just want to sit it out for the first group, just let me know. We'll do that. We'll catch up with you next time. You new guys can reach us at my email, dr.john@ancan.org, or Rick's email at rd@ancan.org. Rick is our founder. He's there with the AnCan background on his picture. So I'm going to start with Gene because I already have a fair amount of information. I'm going to introduce you, Gene, to the guys, and we're going to ask you some questions that we didn't learn last night.
Thanks, John. I hope I have the answers.
So Gene is an 84-year-old man, new to AnCan. He lives in California. Gene started out with some difficulties with both kinds of urinary incontinence. He actually got a urinary sling installed, but it all led to a biopsy and the discovery of prostate cancer. I did not get the year that all this was done.
It's because I remember it was roughly 5 or 6 years ago was the biopsy.
That's what I thought. Okay, 5 years. So he was diagnosed with prostate cancer. We don't know what his Gleason score was, but he now has a PSA of 25. Gene got an MRI early this year, which revealed, as I understand it, one single bone met, and it sounds like it was somewhere in or near the pelvis. He hasn't really solidified his prostate cancer team at this point. He's calling Dr. Schultz. He already has made a contact with a radiation oncologist at UCLA. So just to catch up a little bit, what happened in that 5 years? Were you just being watched for your prostate cancer, or were you actually treated?
No, we were actually on a watch mode, which is why I joined the group yesterday, because I still thought I was intermediate, but the last MRI apparently said that's history. But I was just watching and waiting.
So you virtually had no treatment at this point, right?
No traditional treatment, right? I have my internist is a Eastern Western doctor, and he has prescribed a variety of pills and potions of the natural sort. And I'm an obedient patient, so I took all this stuff, but it didn't really make any difference. But in terms of traditional treatments, I have had none at this point, other than just watching and waiting. And the last MRI.
Is that MRI the only scan that you've had of any sort?
No, I had a Well, I
Get
had
a
a
PSMA scan.
biopsy. I had a PET scan this year, and the MRI.
Do you know if
And
your PET scan was a particular type of PET scan?
I do not. And after the meeting I was at in yesterday, I'm impressed with how much the members of your groups know all of the stuff around their treatment and condition. And um, I just have not been consciously aware or capturing all of that information. I get a test, and doctor tells me what the test shows, and I put a copy of it in a paper file, and I promptly forget about it. So I'm just learning how conscious I need to be of this kind of
Well,
stuff.
there's two pieces of information that might help us share our experience with you. One is the Gleason score from back in your biopsy, if you want to dig that up and share it with us. And the other is the type and results of your PET scan. Okay?
The type of scan and the Gleason score. Okay. Um, I will
Um,
find those
have
for
you
the
got
next
any
time.
family history of cancer?
No, to my knowledge, there's not. Both my mom and my dad died decades ago, but
Oh,
not of cancer.
okay. Do you have children?
I have a son by a first marriage, but he's adopted, so no direct children uh, from my genes.
Okay. Well, as you can tell by my questions, after you see Dr. Schultz or whoever it is, as things get rolling, we're probably going to be talking to you about some genetic testing. But Dr. Schultz probably will do that as well.
Okay,
That's because there
I
are
have
some
my first.
mutations either in the genes you inherited from your parents or in the genes within the tumor that affect what's going to happen in the future. So that's another one of those things that might help help for us to know about in the future. So
I have, I have my
Gene
first
came
meeting
to.
with Dr. Schultz uh, next Monday.
Oh,
So I'll be
good.
much smarter the next time we have a
Oh, good.
get together.
We're kind of predicting that you'll find that very helpful. And if you come back to group next week, you can tell us all about the treatment plan that he outlined, and you can talk to people who have been through everything that he's going to suggest for you and see what it's like and help you make decisions. You're
I will come
probably
prepared.
you're probably not going to be offered surgery, so we're probably going to be talking about different kinds of medications and or radiation therapy, just to give you a little heads up what's coming.
Yes, my last uh, urologist, who I think I mentioned yesterday, Dr. Marks, Leonard Marks, referred me to a radiologist, and I decided I needed a second opinion, so that's why I'm set up with Dr. Schultz
Okay.
practice.
Yeah. Well, Dr. Schultz is a GU medical oncologist. Am I right, Rick?
Yes.
Yeah. So that's different from a urologist, and that's different from a radiation oncologist. You're going to be probably working in the future with a radiation oncologist and a GU medical oncologist. You you don't have to leave your urologist behind because you did originally get to this point through urology and may even still have some urological symptoms that might have to be dealt with.
Did you figure out which radiation oncologist Dr. Marks referred you to, Gene?
I did not, Rick. I actually did nothing except contemplate what we talked about yesterday. So I did not try to run that down. And I have a lot of notes in my office, which I haven't been to for a couple of days. So I need to.
Okay. Well, we can certainly tell you the strength of that medical oncologist. We know several of the medical oncologists at UCLA, and most of them are pretty good.
Gene, are you a veteran?
Yes,
Ah,
20 years Navy.
ah,
Career man. If you're interested, we have a veterans group. It's run by Captain Jim Marshall up there on my screen. He's up in the front row, and his specialty is to help guide men through the VA benefits system.
I appreciate that, and I did see the at a veterans group.
Okay.
My recent experiences with the VA here in Los Angeles have been disappointing. Staff cutbacks, uh, people leaving and not being replaced. I see them from my hearing aids because I have a hearing deficiency. Something about
Yes.
gunfire off the side of a ship many years
Yes.
ago. And so I'm not quite sure what to do about that. But
okay. Well, definitely come by the next vets group, which will be on the Tuesday the 3rd, in the other room, not this room, in the Schmear room. We try to help you with both navigation through the healthcare system, which means dual enrollment, as you are dual enrolled.
yes,
But you will need to get yourself up to speed with prostate cancer, because if you need drugs, you won't find any cheaper place to get the specialty drugs than the VA, as some of the guys on this call can attest to. Now, the problem is you have to have all your docs in place when you need the specialty drug. Otherwise, they'll say you need this specialty drug, and then you're chasing around trying to get that drug. So, for example, if we want to get you onto Orgovyx and your insurance turns you down for Orgovyx, which is a particular drug, you can probably get it through the VA and you can get it quickly. So start putting the wheels in motion to get your prostate cancer docs in place at the VA. Even though it's frustrating, we know it's frustrating, we get it. That said, there are certain advantages to the West LA VA in that they use a lot of UCLA people for their prostate cancer. So you may get lucky and find that the radiation oncologist that you're referred to also works at the VA, and then he can move things along pretty quickly for you. But it sounds like you already have a primary care physician at the VA. Otherwise, I doubt you'd be getting your hearing aids.
that's true. I do. Yeah.
Okay.
Um,
All right. Well,
well, it's
welcome, Gene. So as you can see, what we'll do, we'll start each group with the new guys. And then if you continue to come from now on, what'll happen is that after we get oriented with the new fellows, everybody else has a chance to bring up whatever questions they have. And I think next time we see you, we'd love to hear how your consultation went.
I would love to have some good news to tell you, and I'll do some homework on
Okay.
some of those things that you asked about that I don't have any clue about between now and then.
Okay. And you already know when the next vet group is if you want to attend that, it sounds like.
Yeah, and
Yeah,
you
and
mentioned, John, that it's a different link. Uh, could
If you go on
somebody?
the AnCan website, you'll be faced, as you drill down into groups, you'll be faced with a choice of two different rooms to go to. This room is Barniska's room, but the other room where Jim Marshall's group is called the Schmear Room.
Okay, if there are only two and it's not this one, I can figure it out.
Right.
Yep.
And it'll be, we'll sign you up for a reminder for that veterans group, and it'll be in that too. It'll be in the reminder. So you'll find it in more than one place. Does anybody else have anything? I see Dr. Jeff has his hand up.
Yeah, did I hear you say that you saw a radiation oncologist and then you wanted to get a second opinion?
No, not yet.
No, I did not. I was, Dr. Leonard Marks referred me to the radiation oncologist, but I wanted to get a second opinion on that before I made that connection.
Okay.
Anybody
Jacob?
else have any questions for Gene before we move on? Okay.
Thank you, John and Rick. Appreciate the
You're
time.
welcome, and welcome. Bill, I'm going to do your situation next. If you want to give us a little background history, I'll ask the questions, and you
Sure.
can.
Sure.
Okay, very good. How old are you?
Okay. Still under my urologist care after having my prostate removed in 2020. Slowly
Hold on
moving
just a
towards.
minute, Bill. Bill,
Okay.
hold on just a minute. I want to go in a certain order, or I'll get really confused.
Oh, next one.
Okay.
Okay.
How old are
Sorry.
you?
I'm 63.
Okay. And where do you live?
I live in Fredericksburg, Virginia.
Okay. Now, Gene already knows this, but for the other of you new guys, in the upper right of your screen, there's a little icon that's 2 square blocks with the number 2 next to it.
Yes.
That is our chat. So during the group, there's usually a fair amount of chatter going on in the chat window as well. So maybe if we don't already have your email, Bill, you can go in the chat window and put your email. Rick will take it down, put you on the reminder list.
Yeah, I think we have it because Bill called me. I'm pretty sure that I put him in.
Okay. And Bill, what year were you diagnosed?
I was diagnosed January 2020.
Oh, same as me. And how did that come about?
My general practitioner saw my family history. My dad had cancer and sent me at my age to the lab to get a PSA. It came back a 4, and that was high enough for her to send me to biopsy.
What did the biopsy tell you?
Who did the biopsy?
Yeah, what
It
were
was
your
done in
results?
Fredericksburg. I forget the doctor's name.
Mm-hmm.
The results of the biopsy were that I was a 4+3. We had 12 cores and 5 of them were positive. The worst was 90%. That was the 4+3. I had one at 60%. Both of those were on the same side. I had 3 more ranging from 3 to 10%.
Okay. And was the diagnosis straight out adenocarcinoma of the prostate?
If that means I needed to get it removed, yes, it was.
Okay. And then the next thing that happened is they offered you a prostatectomy, which you got
Yes.
in 2020, right?
Yes, sir.
And did that surgery go well? Did you have any complications or anything like that?
Not at all. I mean, I don't have a lot of the negative symptoms that I'm supposed to have, I suppose. No leakage. No performance problems, so to speak, and no
Good,
pain. I've been very fortunate.
good, good.
I will add, he had a terrific surgeon.
Who was
One
it?
of our one of our favorites, Kirsten Green at
Oh, gee.
UVA, who trained under Peter Carroll, and she's lovely. She's done webinars for us, and I've known her since about 2010. She's great.
I was
Wonderful.
very fortunate.
And then 6 weeks and 12 weeks after your surgery, you had a PSA done to see whether they got it all. And what happened then?
The first one was non-detectable. The second one was a 0.1. No, 0.01. I'm sorry.
0.01 at 12 weeks.
Yeah.
Okay. And what did they do with that?
We monitored, and the third one was non-detectable. I went back to non-detectable. And it's been 4.5 years.
No treatment, no PSA.
We've had PSAs. I'm on a 3-month schedule right now for PSAs. I just had my most recent one yesterday, and it was a 1.1. I mean, 0.11. 0.11. And I did see 2 radiologists yesterday, and that is.
Tell us what kind of advice you got.
The first radiologist suggested monitoring until we get to near 0.2 or over. And then at that stage, hormone treatments, salvage radiation, including the prostate bed and lymph nodes, and more hormone treatments. The second one suggested no hormone treatments and more recent or more, let's do it now without the hormone treatments and proton radiation. And I'm not familiar with proton radiation at all, and or really the other one, but less with the proton.
Okay. And you probably don't have an oncologist, I imagine, right now.
I don't have a GU oncologist. I'm still under the care of Dr. Green and my urologist, and I did consult with the Dr. Allen, as the CU medical oncologist at Innova.
Yeah,
Just
Dr. Allen
just
is a
recently?
GU. Dr. Allen
Yeah.
is a GU med onc.
Are you going to see Dr. Allen again? Or was that just a one-shot deal?
If I like Dr. Allen, and if I choose the program that includes the hormone therapy, I'll see Dr. Allen again.
Okay.
So,
Very good.
which radiation oncologist was the one that Dr. Green recommended?
The Dr. Showalter at UVA.
Yes, and what did he recommend?
He recommended the hormone treatments with the the salvage radiation.
Right, that's what I figured. And I would have guessed that first one came from the Center of Excellence. And where was the second one?
I went to Innova and saw I saw Dr. Eblan at Innova Medical Center up in Fairfax.
Mm-hmm. And what did, just to go back to Dr. Allen, did Dr. Allen suggest what you should do with respect to the radiation?
He said see a radiologist and he sent a referral to Dr. Eblan, and then we called and scheduled with Dr. Eblan.
Got it. And Dr. Eblan, he wants to give you proton radiation. And what does he want to radiate?
Just the prostate bed.
Right. And he's talking about no hormone therapy. Is that right?
That's right.
Okay. Well, and just sorry, John, just to pursue, let's just talk about the genomics and then we can give some feedback and get some comments.
Has anyone done any testing for your genes?
It's ongoing, and it's being done by Dr. Eblan.
Okay. And was it done by a cheek swab, a blood test, or your biopsy?
The biopsy.
From the biopsy. Okay. So that's pending. And you can also, by the way, have another genetic test from a cheek swab or a blood test to see if you inherited anything from your father
Right.
that made you more vulnerable to prostate cancer. We suggest you do that.
Or mother.
Excuse me?
Exactly. Well, you could have inherited a gene that made you vulnerable to prostate cancer either from your father who had it, or even your mother who didn't even have a prostate but still could pass on to you a vulnerability.
Okay.
So it's probably a good idea. Have you had any kind of scans?
No.
Okay. And are you a veteran?
No, sir. No, I'm not.
And I imagine that you're on the point of a major decision right now about treatment. But what else brought you to us? What else would you like us to help you
Well,
with?
we do prefer to go to a center of excellence. I understand there may be one in Richmond also that we're not familiar with, and we're going to explore that. We just want the right, I guess the term is quarterback, to
Yeah.
join our team and help us through the next phase of treatment.
Yes, we would
And
like you to have the right quarterback also.
thank you. And that is why I'm here. Maybe
Now,
you can point.
yeah, I'm sure we would be very comfortable with you at UVA, but we'll talk to the guys about all their experiences with some of the different people that you've seen and the different treatments that are being proposed. As far as getting that test for your what we call germline or inheritable genetics, Rick just posted a website where you can get free germline testing. So it's up in that chat box that I was talking about a little while ago.
Okay. Thank you.
Just click on the link, it'll open and you can look at it later. It'll open in your browser and you can look at it later.
Okay, thank you.
Okay, so we got some good questions here and a lot of guys in the room who have been in your spot. I was in your very spot in the spring of 2020. So I'll open it up for discussion. Rick, other questions or anybody else who can relate to this story?
I do have a few ideas, but I don't want to jump in right at the beginning. Let's see what other people have to say first. Everybody's so quiet today.
Okay, so I'll jump in here. I think I was in the same position you were, and I went to see a GU oncologist, and the way he explained it to me is, okay, we're going to use the hormone treatment, Orgovyx, to weaken the cancer, and then we're going to go in and zap it with the radiation. And that was his plan. And for me, that worked really well. But that's how he explained it to me. No, I wanted to say, do we really have to do the hormone treatment? He said, yes. He's pretty straightforward. He said, yes. And I asked the radiologist, he consulted with a radiologist, and I asked her, well, it's not, my PSA is not that high. Can we postpone this? And her face turned white, and she said, absolutely not. So
Okay.
they wanted to jump in with both, and I'm really pleased that I agreed to do that.
Jim
Okay.
Marshall.
Yeah. Right now, I'm attempting to figure out how they can determine a treatment provided that they haven't done scans. Okay, and we're to find out precisely where it is. So how does that work?
I doubt whether Bill is going to be able to respond to that because he's trusting his docs. But I think what Jim is saying is we don't have enough information to know where to go. So Dr. Eblan's recommendation to jump in with radiation right now may be a little premature. Is that what
Okay.
you're saying, Jim?
Yeah. Premature, but still after that, ADT starts and you still don't know where it is. So I would think a scan would be a thing to do up front to find out exactly where it is.
We'd agree with that.
Yeah, and I would add that Dr. Gainesman also had a PSMA done, a scan done before he started treatment. But it didn't show anything, and he still started the treatment.
I
Go
I had
ahead.
a thought on that. Okay. The understanding I have of the radiation, whether it be 33 or 38 visit, would be that they do the whole prostate bed. And I also under understanding that they may or may not do anything that is spot radiation because of the condition of what's left in the prostate, including your urethra or whatever, which may have been repaired, and they don't want to get anything close to that with the spot radiation. And that's the way it was explained to me, that we're not going to be doing the spot radiation anyways. We're going to treat the whole bed, and we know it's in there because that's where your positive margin was. That's the way I understood it. I might be misinterpreting everything, but that's the way I understood it.
Yeah, I think you can't do spot radiation where you don't know about a specific spot.
Yeah, but they
Yeah.
don't plan on doing any spot radiation. Yeah.
Well, I think the
Bill,
point we're trying to make to you, Bill, is that
Okay.
that they don't have that they're not talking with full information. We don't know if
Okay.
you have a spot. Do we know if you have a spot or not? They're just assuming from 5 years ago this is where it is, but they don't know because they haven't done a scan. What happens if we found a spot on a node or a spot in a bone or somewhere like that? Would that change it? So in other words, you got to go back to Eblan and say, Dr. Eblan, how do you know that it's right there? And he'll say, well, that's what my professional judgment tells me. And you say, well, could it be in the bone? The likelihood is, and I get why they're saying it, you've done very well over 4 or 5 years. You don't have particularly aggressive cancer. Your PSA is low. It would seem there's nothing to worry about. But the fact is, we got to check it, and we don't want to check it after you've done the radiation. We need to check it before you've done the radiation. I'm also concerned about Eblan's willing to jump in right now when he could let you go up to maybe 0.2, 0.15, 0.2 and do a PSMA scan. And I'm also concerned that he's not interested in looking at the pelvic nodes, that he just assumes that we just got to radiate the prostate bed. And he seems to want to do that with a proton machine, and that bothers me. Now, before I say any more about Dr. Eblan, Joe Blanchette has his hand up, and we know that Dr. Eblan's done some very good spot radiation for the general. Go ahead, Joe.
Yes, Dr. Eblan would definitely be taking some scans, especially MRIs and PSMA PET if he didn't have a current one before doing anything. He's very good at. I happened to come to him with all my scans already, except for the MRI, and he liked that, and he didn't have to ask for them himself because I already had them. But he was very diligent at running scans to make sure he knows exactly where the cancer is before he starts radiating. So I wouldn't be worried about that, in my opinion. I've seen him through 6 treatments already, six SBRT sequences.
Yeah, but he wants to start radiating right now, Joel.
Yeah,
And
well,
he's not even mentioning him getting a scan.
yeah, that I can't explain.
No.
Oh, we're right there.
Glenn?
Yeah, we're right there. Yeah.
Yeah, thanks, John. I think I know where Rick was going to go, so I'll go there. The D'Amico study, is that the one you were thinking of, Rick?
Yeah, the
Uh,
0.15.
yeah. So there was a study done, published in JCO, Journal of Clinical Oncology, by Anthony D'Amico at Dana-Farber, where they showed that you increase prostate cancer specific mortality and all-cause mortality if you wait beyond 0.25 before you run a scan on patients like yourself who, after prostatectomy, have a recurrent PSA. So their recommendation is to get it done, get the scan done before 0.25, preferably whenever the insurance company will cover it, however early they will cover it. Certainly they'll cover it at 0.2, but if you can get it done sooner, that's better still. So yeah, that's it from me.
Good to know.
You know, your story is very reminiscent of my story. I was your age when I I was detected and I had a prostatectomy. I'm 85 now, and
Congratulations.
I'm at the age of 63. I had a diagnosis with low PSA, margins clean, all the good parameters. Prognostically, no chance, no radiation, no adjunctive radiation, no hormones, nothing. And 15 years later, it came back. So it was somewhere in my body. The assumption everybody made as soon as it came back, it's in my pelvic bed or somewhere around there. So they immediately wanted to do radiation. They wanted to do radiation prophylactically where it was 0.1. And they assumed they could knock it out and then it can go for curative intent. And I had a quarterback who was a chairman of the Department of Urology, Peter Scardino, very knowledgeable guy, and he said, no, let's just watch and wait. Let's just see, because he must have known somewhere in his head that it could be elsewhere, and it could show up, and theoretically, a lot of people want to go in there, and medical oncologists want to go right away with the drugs, and radiation oncologists want to go right away with the radiation, because that's what they do. And maybe I should have done it, but now in retrospect, I'm glad I didn't do it, because it never landed in my pelvic bed or my prostatic fossa. It ended up in the lymph node in my lung and on a couple of bones. And it's now 22 years later. And I'm being treated with radiation and SBRT and long-term androgen deprivation therapy and, that combination, doublet therapy. So it's a real strange. I don't want to scare you, Bill. I mean, but this is what happened to me. So, and I had my first scan when I was at 0.17 before they were doing scans, except in male, and I did something called the C11 choline scan. And I did that because I wanted to nip it in the bud. If it was in the pelvis, let's attack it. They didn't find anything. Said, come back when it's higher. Then I had my first PSMA scan. As soon as they came out, they didn't find it. Then I had another FDG scan. They didn't find it. Then I had another PSMA scan and an Aximum scan, and they finally found it. So it could be tricky. And maybe I'm a unique situation, but I found out subsequently I'm not so unique. So it happens, and maybe infrequently, but it does happen. So be prepared for the possibility that that could be, and that there's value in getting scanned, because it could be a little thing up there somewhere other than in your pelvic bed. Hopefully not, and they can radiate your pelvic bed and your prostatic fossa, and you'll have curative intention. That's my best wishes for you. But I just thought I'd share my fluky history.
Thank you very much.
Let's go to Dan, and then I'll sum up, see if there's any last questions, and then move on to our next new guy. Go ahead, Dan.
Yeah, I just want to reiterate what other people are saying so far. I've got 10 years on you, but my Gleason was 4+4 or 4+3. They wanted to do surgery, and I waited for a minute until I got to this group, and I declined that and did hormone therapy and radiation therapy. But before I made that decision, I found out from this group they needed to do a PMSA to find specifically where those cancer cells were. And they found most of it in the gland, maybe a little bit on a lymph node outside, and possibly on the liver, which really threw up some red lines. In the intermediate situations last week, they did an MRI on the liver. It's false positive, so that's good. But I just came through 25 sessions of low dose and 3 sessions of high dose. I would not even let them do that without doing a PMSA. You've got it, just like everybody else said, you've got to know where it is. What they're what's the target they're shooting at?
For the, not sure what, the prostate bed is where they're trying to treat, director of treatment.
Yes, but there could be 1 or 2 cells beyond that, which they never could find without doing the PMSA. So
yeah, that's right.
PSMA, just to be sure we're clear, in case he's taking notes.
Bill, if that was a spouse in the background that we just heard, anybody is welcome. Oh, I thought I heard somebody whispering something or other.
You did. She made a request not to involve her, but she knows a lot more about this than I do. But
all right, well, she's welcome to join in whenever she wants, or stay out whenever she wants.
We love having spouses involved or partners involved, and she's really welcome, and she shouldn't feel
well, she's here to hear some knowledge right now, just hearing that. So thank you.
Okay. Now I'll just give my 2 cents and then let John sum up. If it were me, I'd stay at the center of excellence, and I get everything done at UVA in terms of the radiation, because I like the approach of that radiation, Doc. I am always very nervous about salvage radiation that is too skimpy, because all too often we've seen that skimpy approach result in recurrence later on. And I just don't see the sense in skimping on that salvage radiation. But that's my own personal view. It's not a medical view. It's just from my experience. Secondly, I would stick with Dr. Allen, because he's young, but he's good. I do not like Dreiser at all at UVA. I wouldn't recommend somebody sees him. I just saw him on a list of the 150 best oncologists. He wouldn't be on my top 1,000 because I don't like the way that I know people who he's treated, and I don't like the way that he's been treated. And so, as much as I respect Dr. Green, and I really do, and she can give you a good RO, I think it's good to keep Dr. Allen in play. So I would some point split. You don't have a lot of good choices for genitourinary medical oncologists in Virginia.
Okay.
And I'm pleased you're with Dr. Allen and not with Dr. Aragon Cheng, because and I'm talking personally, but she's on the
Okay.
same list that Dreiss is on for me personally.
I understand.
So that would be my 2 cents. Stick with the UVA if you can. I realize it. Well, no, you're in Fredericksburg, so it's not too inconvenient. Stick with
No.
UVA for the radiation, and then go to Dr. Allen if if you need follow up with the hormone therapy and see what they want to do. And above all else, don't do anything until you have a high enough PSA level that you can do a PSMA scan. John?
Well, that pretty much sums it up. That's just about what I was going to say. So we'd love to have you come back. We want to see what Dr. Allen thinks. If you manage to get your PSMA PET scan, we want to hear where this is coming from. We don't want you to waste time. You don't have to panic though, because it's taken 4 years for your cancer to even get to a PSA 0.1.
It may be a while before that PSMA's done, because I'm creeping up there to that 0.15. I might be a little while, but I'll be back when it's done.
Find out from your insurance company if they'll do it at 0.15 or even at 0.11, and see what Dr. Allen wants to do. And share your somatic genetic testing with us when you get it. And we meet 4 weeks a month. So it's the first and third Mondays, the second and fourth Tuesdays, although I don't know what next month's schedule is going to be like. It might be a little messed up, but just Rick will keep you informed by email.
Thank you.
And we're delighted to have you.
Thank you very much.
I'm going to move on to Steve.
Thank you,
Are you
Rick.
still here? Oh, yeah, there you are. Hi, Steve. Can you unmute your microphone?
Okay, here we go. Oh.
So are you dialed in as well as on your computer, or what? What happens is when you unmute your microphone, they start echoing back and forth between your own mic and speaker. So we need only one live mic somehow.
How
Try to
about now?
unmute. There. Oh, that sounds good.
Okay,
Good.
it's good.
Yeah.
No,
Okay,
it's
great.
not. We're still
Oh,
getting
no.
we're still getting a echo, Steve.
Oh, yeah. Now I hear it.
So I guess I got 2.
Apparently, you're signed in twice, and one of them has got to be stopped.
I don't see a second sign in.
Oh, you think these are? But
I
he's
see
got
2. One
He's
Oh,
got
you
says
do?
two.
empty, the other says waiting for name.
I don't have a waiting for name on this screen.
Oh, you don't? I do.
I just see the one say waiting for name.
Okay,
Well,
so
close that
So,
one out.
yeah, so if you see a waiting for name, John,
Yeah,
just dismiss that waiting for name because I don't see it on my screen.
that's the one with the picture, though.
Yes, it's one
Well,
without the
any other?
picture that says Steve Collins. I
Yeah,
don't
the other
see
one
it
just says
anymore.
Steve Collins.
If someone
Let
could
me
delete that one,
Okay,
let
you
me delete the one that says that doesn't have a picture and see what happens.
okay?
This may be a disaster. Let's see what happens. Okay, now unmute yourself. And somewhere at the bottom of your screen, there's a microphone icon that's crossed out. There you go.
There
you
you,
hear, you hear me
Yeah,
better
yes,
now? Hey,
yes,
good.
all
perfect.
right, all right.
You want to go through the same routine with us that you
Yes,
just saw?
okay,
Oh,
great,
good.
got it. Thank you.
How old are you, Steve?
58 years old, from
Where
Metro
do you
Atlanta.
live? Oh,
I live in
Atlanta?
Canton, Georgia, outside of Atlanta.
Okay. When were you diagnosed, Steve?
First time I was diagnosed is November 2013.
And how did that come about? Did your PSA go up, or were you there for urinary symptoms, or what happened?
No symptom, just regular physical, which I go every year, and my PSA number had got up, and my doctor said he thought I should see a urologist. They did a biopsy. Out of the biopsy, I think they took 12, uh, 2, 4, 5, 7 of them was positive. My Gleason score was 7, 3 plus 4, and I had a prostatectomy, radical prostatectomy, robotic radical prostatectomy. I guess that's how you say it.
What was your PSA at the time?
Uh, okay, I think it was 4.7 or something like that.
Okay. So you had a radical prostatectomy, and then what happened?
Went from 2013 to March of this year undetectable. I had no
Wow.
radiation, no chemo, none of that.
Wow.
Uh, very minimum, if any, side effect from it, like incontinence. He had a little drippage, but that got stronger, got back to erection and all of that. And then March of this year, just another regular physical. They say my blood work, my PSA went back up. So,
How high has it gotten?
I think it was 7.8. Then I took another one. No, excuse me, it was 8.2. Then I took another one and went down to like 7 something. And then they sent me to get the PET PSMA scan.
Yeah.
And it showed that it was in the prostate bed and next to my lymph node. And that's where it showed up at. So after that, I was sent to see a radiation oncologist. And his suggestion was that I do 40 treatment, 8 rounds of radiation, 5 days a week, for 8 weeks, and also do the hormone therapy, ADT. And I haven't started, but tomorrow, the first day I go in for my MRI to get started with the process.
Okay.
But like I said, I was just free for 11 years and I just kept taking, even though they told me I could stop taking the PSA test, I kept taking them and boom.
That was a good idea.
Oh
I
yes.
know it was looking like you were done with it forever, but that's not the case.
Right.
So a 3 plus 4. Okay, so now you are about to start your IMRT or whatever radiation therapy you're about to have. You have a recent PSMA which shows prostate cancer in the prostate bed near a lymph node, but actually no actual lymph node metastasis, right? You're
Right, that's how I
about
was told.
okay.
Yeah, that's
You're
how it was told to me.
about to start ADT in preparation for your radiation therapy. And your
Correct.
MRI is pending to see if they pick up anything that the uh, PSMA missed, or also to get you all lined up properly for your radiation therapy.
Correct. They said the MRI is going to be of my prostate.
Yeah. Okay. And maybe if you're lucky, you'll get a radiation machine with built-in MRI imaging and very sophisticated stuff. Might be nice. So, did you get any genetic testing yourself?
No, last time I ordered I just got last week the kit where you do the swabbing.
Okay.
My results from the what you call it, from the biopsy was that I had, how you pronounce, adenocarcinoma.
Yeah.
That was the type, which I guess my research showed that's the average type prostate cancer that it is.
That's right. That's right.
And I was looking
Okay.
at my surgeon pathology report. What was interesting is that when he did the surgery, he said he took out the part of the lymph node and it was negative for cancer. But I guess I don't know how it would have been taken out, and then now it said that it's close to it. I don't know.
Right.
Well, it seems like what happened is your surgeon not only took out your prostate, but also probably took a sampling of lymph nodes, none of which had cancer in them.
Correct.
Now, many years later, you have a spot of cancer growing in the prostate bed, which sounds like it's at least near a lymph node. Who knows? Maybe it's in it. Can't really tell from your description.
Yeah, when I read it, and the doctor he said it was near the lymph nodes.
Near. Okay. Well, that's good. That's good. And any family history of cancer?
Yes, not my father, but my mother. My mother died of cancer, and so did my sister.
What kind?
My mother had a very rare form of intestinal cancer.
Hmm.
My sister died of lung cancer. Never smoked or drank in her life before she ever
Oh,
died. Never in her life.
Yeah.
okay.
50.
Oh boy.
Yeah. I lost Steve. I lost a very dear friend in the same situation many years ago. And it
Okay.
happens. It happens. It
Yeah.
happens.
Yes, that's what they were saying. And my oncologist was asking me, radiation oncologist, I guess it's different than a medical oncologist. He was
Yes,
asking me, he was saying that there's a link to, I guess, women with breast cancer and men with the prostate cancer. Because he was
Yeah.
asking
that's
did my
right.
mother have breast cancer. I said, no, she
Yeah.
didn't. But, yeah.
Yeah.
Hmm. And that's why
There
you're
are a
doing
number.
that swab.
Yeah, exactly. That's why you're doing the swab, and it'll come back and tell. And as I recall, you're getting treated at the VA. Is that right?
No, Northside Hospital here,
Oh, North
Northside
Side.
Cancer Center.
Okay.
I am
But you,
a veteran, though. The VA are paying for it all.
okay,
But
the
they're
VA
allowing
are
what I'm
paying
doing.
for it. So, okay, so this is through the VA, but you're doing it on their community plan. So, got it.
Yes, yes, sir. Yes, sir.
And how did you get to us? And what are you looking for?
Well, I was referred to the veteran group by Sylvester Mann,
Yeah.
and then when I was in the veteran group, Mr. Marshall referred me to this group.
Okay.
Um,
What questions do you have, or anything particular that you'd like to get out of joining us?
Well, to answer the question and what I'm looking to get out of it, obviously, is speaking to other men that have been through or going through uh, similar situation, and I'm sure that it's different from everyone. And for me, I've been through that other part, that 11 years of getting back, getting your body back, and getting. Now it's all new to me what I'm about to go through now, and
Yeah.
sometimes I like to ask the question. It might not be a good question, but I was saying, if there's anyone in the group that probably, beyond the radiation, the ADT treatment, and how has life been for them, beyond that.
Yeah. We've most of us been on ADT, and probably the majority have had some sort of radiation treatment. So we have a lot of experience that we can share with you. And this is going to be your first time on ADT, even though your diagnosis was a long time ago. So
Correct.
you're
He
in
said he
for.
would probably recommend I do at least 18 months on the
Yeah.
ADT.
Okay. And who was it that recommended that?
The urologist that excuse me, the radiation oncologist, which is Dr. James Williams, he's working with my urologist. He said he was going to recommend to the urologist while I go through this treatment that I'm on ADT at least 18 months.
Okay. Okay, I'm going to open it up for discussion from anybody. Jeff.
You're muted, Jeff. Unmute and start over.
Sorry. So what drugs have they discussed with you starting in your androgen deprivation therapy treatment?
Urologist, he haven't really gave me a name to the drug yet. He sent me to see the radiologist. Then he told me I would do radiation. Then I go back on October the 31st to see the urologist again. He said I could take a shot the last 6 months. I don't know what the name of the drug though.
So do you have a medical GU oncologist?
No, just a radiation oncologist now.
I would suggest that you ask them to hook you up with a GU medical oncologist who will make better choices for you in terms of what drugs or combination of drugs you need. Because there are many choices. There's injectables, there's oral, there's multiple different medicines to give injection wise. And then the question always is, do you need a second line drug in addition to just getting Lupron or Firmagon or whatever they pick?
Okay. Yeah, he
Yeah,
did tell me I had an option of oral, taking it by mouth as well, but
Yeah.
Yeah,
still no name of it. Yes.
it's
well,
Orgovyx is the name.
yeah, there's only one that you can take by mouth, and it is available through the VA, and that's the drug that I think most of the guys would probably opt for because it's probably a better drug. The other thing is, if they're going to give you a shot, don't let them give you a 6-month shot.
That's good.
Because what our experience has been that it can, in some cases, wear off in the fifth month. And also, if they're going to give you a shot, they've got to, depending on the shot, they may have to give you something first. If you take the pill, you don't have to worry about that. And the nice thing about the pill is what we've seen is that you recover much quicker when you come off of it.
That's excellent information.
So I think the pill is the way to go. There's only one, so I won't confuse you with any names or anything, but
Okay.
there's only one. And if it were me, that's what I would be asking for. Dr. Jeff's point about whether you need an additional drug, that's also a question for Bill Idoni. I don't know. That's a call really that a medical oncologist could make. Maybe your radiation oncologist if it were me, I wouldn't be trusting my urologist to make it, although there's a lot of urologists who do like to make that call.
Okay. And what's the name of the pill, Rick?
It's cool. I'll put it in the trade name for it is Orgovyx, and I'll put it in the chat window for you right now. Okay.
Okay. Is it common that both treatment is administered at the same time, as far as the hormone therapy and the radiation?
Yeah,
No,
usually they'll start the hormone therapy maybe a month before or something like that, and then the radiation.
Yeah,
Is that what you were going to say, Rick?
The reason they like to start the hormone therapy early, although it's starting to get more controversial, is that they think it weakens the cells and makes them more responsive. But there's been recent research that was mentioned by a radiation oncologist at a big patient conference recently that says that now they're not sure if that's the case. So some give it before, some give it at the same time, and some start it after. If it were me, I'd do it before. That's what I did. I mean, you asked the question about what's it like and how do you survive. I'm not strictly comparable to you because I didn't have surgery in the first place. I had radiation, but I had radiation and hormone therapy, and I was very lucky that it didn't come back. And I was stage 3. I was not stage 4. Most of the gents in this room are stage 4.
I remember the first time when I had the surgery, he said I wasn't even a stage then because where it was located at, I guess. But they haven't told. Well, actually, when I did talk to after the PET scan, they said I know it can't be curable because it came back, but they said I was in a low area of concern unless I didn't do anything.
Yeah, I mean, it's the same like Bill. I mean, when it doesn't come back for a long time, we don't have to worry too much. I mean, I'm a little bit concerned that they are only talking about radiating the prostate bed because I think, they may want to do a bit wider. I do think, and I'm terribly sorry, we got to move on because it's getting late and we got a lot of questions. And I think we just got to keep pushing forward, John. But hopefully we've answered all your questions, Steve.
Oh, I'm fine. I appreciate you guys.
Do we have your email address, Steve?
Yes, sir. You should have it. I put it. I sent it. Put it in the group chat. I think I put it in the one that we had to delete. So I just
All right.
put it in the chat.
Well, welcome to the group. We're happy to have you here, and hopefully we'll see you again. We'll be able to follow you through the decisions that come up in the next couple of weeks.
Can't starting ADT early. Let's shrink your metastasis a little bit so when they do the radiation, they're not as large. I know of one person where they had numbers on every one of them and they were all shrank.
That's the old thinking, Jeff, and people have based treatment plans on that for many years. It's just come into doubt recently.
Well, look like I'll be in front because I'm doing the radiation. I won't even see the urologist until October the 31st. So we'll see. But we can move on.
Okay. Maybe we'll see you next week.
Yes, I will be here.
Okay. Counting the numbers here, we're going to have to average a little less than 5 minutes per person because I have quite a few people, but I hope we get everybody's questions taken care of. Let's start out with Bill Lee.
Okay, I don't know if you can see me. My camera decided to stop working.
No, we don't have a picture.
Okay. Quick update. Last week talked really quick that yeah, I thought I was having something going on with the bladder. But actually, we'll start off with today's my birthday.
Happy
Happy
So
birthday.
birthday!
everyone, get out your birthday bingo card.
Yeah.
What did Bill do on his birthday today? Who's got cystoscopy going for him?
Oh no!
That was
Oh,
my second
Bill!
guess.
That was the second guess.
Oh, Bill, we're so sorry.
But we did find out what the deal is, so they just got to call me back with a new schedule on when they can get in to pull it out. What it was they went in with the camera. Well, everything looked clear. You can see where the radiation did its job on stuff. But then they got down there and he goes, "Oh, wow, you do have a stone." No. Oh, wait a minute. That's not. Oh, I know what that is. One of the plastic surgical clips when they from the prostatectomy.
Oh, Jesus.
No shit.
And that was
In the bladder?
no, it's still in the urethra, and
In the
it's
urethra?
yeah, and it's blocking it about
Oh,
7/8 of it's blocked. So
oh
that's
my
why it's
gosh.
like I go to the bathroom every 10 to 40 minutes.
Oh, Bill.
Um, you go, then it once it starts, then it stops instantly. That's why it felt like it was a bladder stone blocking, plugging it up. But it's just
Oh.
everything plugging up, and then it drizzles out. Then I get done, I walk away, and about 5 minutes later, run back in, go again. Then I'm fine for a little while, and then hematura was the main reason I was going. So it was for the last 3 weeks was getting worse and worse, and so anyways, so now we know what it is. Just gotta get scheduled to because they're gonna have to put me out to get in there to try to. I don't know what they're gonna do, cut it or. I mean, I know they'll put a. He said you'll have a catheter put in. You have to be
Yeah.
on that for a little bit. But. So yeah,
So,
it's a pain in the tube.
yeah, no
Sorry to
kidding.
hear
Were
that.
you able to see the screen while he was doing the cystoscopy?
Yes,
What did the radiation cystitis look like in your case?
it looks like varicose veins.
Okay.
It's pink, 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 pink. All of a sudden you see all these red stripes.
Yeah,
Um,
that's just what mine looked like. And but no active bleeding from up there.
not from that area. Once they got down to this where the staple is, that you could tell that's where them.
I got
Oh,
you.
it's really
Okay.
calcified, and so hopefully once they
Was,
get it out, all my issues will go away.
Yeah.
Bill, was it Carmenos? Was it a surgeon at Carmenos who did your surgery?
No, because through he's associated with Carmenos, but it's through Wayne State University, urology.
Yeah, well, if
And
they
it's
left a clip, if they left a clip in, I'm not the lawyer on this call. I don't know that we probably have a couple, but if they left a clip in, you probably have a case if you want to pursue it.
well, that's what I was wondering. Is like, well, is that left in on purpose or
Did you say it was a
Nope.
clip or a staple?
it was a plastic clip?
It doesn't belong there.
Okay.
Yeah.
At least that's what this it's a younger guy that did the scope.
Damn.
Hey,
That's
Bill, you may think, I know time is short, and you may think this is a joke, but uh, I have this problem where I go to urinate, and then like 5 minutes later, I have to urinate again. It seems like my bladder, since radiation, it seems like my bladder, you know, doesn't hold very much, and I have to do it in 2 steps. And I have a name for it. I call it a double tap. So when I'm driving my car and like I stop at a rest stop, or I always make sure I wait another 5 minutes, walk around the store, and have a double tap. Sometimes a triple tap. So I really would want to recommend the double tap or triple tap. Just wait that 5 minutes and go again. Then you might get an hour, where you don't have to go again. I do that at
Right.
night. Just a suggestion.
Yep. And that's what I do.
Tap and
Yep.
triple tap.
All right. Well, remember this next year and don't schedule anything like this on your birthday again. That's
Well,
my
again,
advice.
it was like I knew this was getting worse and worse. And last week when I was in the office, they said, okay, we need to have a cystoscope done. And she goes, well, the earliest we can get you in is on Tuesday. I said, okay, I'll take it. Then I got home, then realized, wait a minute, it's my birthday. Happy birthday to me. So that was it.
Oh, too bad. Okay. Um, Keith is next on my list, but I don't see him anymore. You still here?
I'm still here.
Oh, okay. Oh, there you are. Okay.
Yep. Okay. And I'll try to keep this real short. I'm innumerable metastases, and last we spoke, I was starting Pluvicto. I've just come out of isolation from my first Pluvicto, and a bit of positive news is that I probably had about a 20 to 25% reduction in bone pain within
Oh,
2 to 3 days.
oh,
So that's some really good news. My PSA going in, when I think we last spoke, my PSA was 25, and when I went in for Pluvicto, for the first Pluvicto, or the pre-labs were 45. So continuing aggressive growth, but a positive first approach. I did have side effects with nausea and vomiting. Weirdly enough, in the first 2 evenings, in the deep night, after midnight, before 4 a.m. for 2 days, and Zofran helped, but didn't really cut it entirely. So another, I think actually it'll be 8 weeks for me because I'm going to Hawaii. I'll be going in again, and hopefully I can get another 20% reduction. I'll leave it there unless anybody
okay.
has questions.
How many
Very good about
infusions?
the pain.
How many infusions did you say?
Just
The
one.
Pluvicto, well, it's
How,
first infusion, and out of 6 that are
Yeah.
that I can do.
Oh,
The goal hopefully will be that we're going to scan either after the second or after the third to decide whether we'll continue the course. But
and Keith, the other thing that we're starting to learn, and Tanya Dorf said this at the PCRI conference, and I think isn't she's
yes,
your
Yes.
medic,
yep,
not everybody needs 6, and
right.
that you may be able to stop after 4, and so be sure to do. Hopefully this is going to go great. It's going to drive your PSA down and everything else. But if you can get 4 under your belt, which is going to take you, that's going to be around 24 weeks or so.
Yep, right.
Be sure to talk to Dr. Dorf about how many do I need, because she's very empathetic. Not to do 6 if you don't need 6, just because it was approved, just because 6 were approved.
And those are almost directly from her mouth, Rick.
Right.
And that we can always put 2 in our back pocket and have them in the future,
Exactly.
right?
Yes.
So
Yeah, exactly. Any other Pluvicto gents on the call today to give Keith some support after his first treatment? I
But
don't know if there are.
one question that I had is we were going to see if we could get Dr. Dorf to resequence you before you started the Pluvicto. I assume that never had a chance to happen, right? Or you would have mentioned it.
She was resistant, and said that
Okay.
was not the, not their standard of care and was really unnecessary. We also talked about doing alternate scans. Um, the to speak on her behalf, the PSMA scan images I've seen, the best terminology I can use is that I light up like a Christmas tree.
Yeah.
It's everywhere, and so um, getting on top of it at least before my PSA went to 50, which I understand is a good marker for success for Pluvicto.
That's okay.
So
We're not about to argue with Dr. Dorf.
Well, I will say this. I did get a zinger in at PCRI, and I said to her that we really feel that given the research that's coming out, whereby PSMA, sorry, the radionuclides may be dependent on mutations, that there should be an accompanying
test.
um
Yeah.
somatic sequencing before a man starts. And she didn't say no. So, I think we just have to keep banging on these medical oncologists. It's great in your case
Yep.
that you responded. But if you
Yeah.
hadn't have responded, we might have been saying, well, why the heck didn't they test him first? You know what I'm saying? And
Yeah,
yeah, I mean,
absolutely.
it
And
is a
yeah,
standard of care, but it's not standard of care. But a good doc should do it because they know, because now they're seeing that the mutations matter whether you're going to respond to this treatment or you're not. Anyway,
yeah. I get it, Rick. And as you mentioned, it's hard to go toe to toe with Dr. Dorf. Um,
yes,
prob,
agreed.
maybe one of the top 10, and she's been great. And yeah, I'm getting the attention I need. So that's the good news.
Okay.
Um,
Excellent.
on
Any
a
other
quick,
comments from somebody that's been on Pluvicto before we move on? Or go
let me
ahead,
just
Keith. You had something else
let,
to say. I just
let
wanted
me
to see if
publicly Yeah, let me publicly thank Harry for sending a wave, an Ember wave, to me, and I bought a second one now so that I can wear one 24/7. It really makes a difference in my life. So,
Oh,
Oh,
good.
good,
yep.
good.
And
And,
if
and
anybody else, especially people who are starting to go on ADT, I've had extreme hot flashes, and this wristwatch that I wear on my wrist allows me to reduce their intensity by, I would say, 50 to 60%. So
Oh, terrific.
I
EMBR wave.
So you new
yes,
guys that are about to go on ADT, if you get really terrible hot flashes, bring it up in group.
Yep.
yeah, we have a few solutions. I think Harry left. I think I just saw him leave, but I
Okay.
hope you've told him how
I
good it's
did.
been for you.
I,
Good.
I, I,
Thank
I
you.
have, and yes, and he was very generous in sharing his device that he had because it didn't work for him. So hopefully someday we can pass these on. So now I have two.
Okay, that's great.
Jeremy, Jeremy, what do you got?
I'm, well, it sounds like previous guys have had similar situations. I'm a post radical prostatectomy, 3 years with rising PSA, Gleason 4+3, positive margins at the bladder neck. Um, uh, Getting planning right now, planning stage at City of Hope in Irvine with Percy Lee. I discussed the last time that I was going to be entered into a clinical trial with this curium tracer, uh, which traces actual prostate tissue versus PSMA, since my PSMA PET scan was negative. But I fell out of the clinical trial because we redid my PSA and it's down to 0.16 versus zero point 0.2, but the zero point 0.2 had been taken shortly after I had COVID. Now, I guess when you have COVID, your PSA can go up.
I
which
didn't know that. Huh.
I wasn't aware that they say can go up quite a bit.
A
Um,
false increase or a true increase? Do you happen
I
to know?
I don't know. All I know is I had before the curium trial, they made me take another PSA and it dropped below 0.2, and that's the cutoff. So I'm no longer a candidate. So Dr. Percy Lee at City of Hope said, you know what? Let to 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 address Rick's concern about sort of flying blind in terms of the radiation scope planning, he decided to do an MRI prostate scan. And they're going to map it over the previous PET scan, which was negative, but when you put them two together, you can maybe see things that they didn't see before. I'm not aware of this. Maybe you guys can speak to it. And that's kind of where I'm at. But the plan is right now 38 to 40 treatments, low dose with Orgovyx. And I can start at any time. Now that I'm no longer a candidate from Curium, I guess I can start it unless there's a contraindication to take the Orgovyx prior to the MRI, which I don't know if there is or not.
Not that
So
I
that's
know.
where okay. So that's where I'm at. Anybody
Well,
have any
yeah, I mean,
on
the only contraindication, and it probably wouldn't happen, is that you don't really want, if you're looking to see where the cancer is, you don't want to be taking the hormone therapy before
that's
you start.
right.
So I probably would get I mean, it's unlikely it's going to work so quickly. I mean, things don't happen that way, but that's it's best to get it done before.
Yeah.
So
And it's a prostate MRI with contrast.
Okay.
okay.
So I'll have that on October 2nd, and radiation's supposed to start within a week or so after that.
And aren't we
And
waiting on genetic testing on you too?
No, I had all the genetic testing. My
Oh,
germline was negative for mutations. The promise / color test was negative for mutations. My decipher was intermediate high risk from biopsy. Again, the Gleason was 4+3. And again, thanks to Rick and AnCan requesting that post-op biopsy was really critical in in addressing the radiation strategy, since there were positive margins in the bladder neck near the site of the anastomose, where the bladder and prostate are joined, I guess. And so given that, the plan is to blast that area with a little bit higher intensity. But again, to again, what you guys have brought up is with negative scans, they do want to try to find out, and the PSA is still so low, they do want to see if they can pick up anything. And I don't know if anything will show up on the MRI. Dr. Lee at City of Hope seems to think it's likely not going to show up anything.
yeah.
And
Okay.
that's where I'm at. But
Okay.
So
given that
your most recent PSA is what now? 0.1?
0.16,
0.16. Okay.
yeah.
Okay.
It had creeped up 0.16, 0.17. Then I got COVID, went on Paxlovid, had another PSA, and it went up to 0.2, and then it dropped back down to 0.16 again.
Yeah, and I just want to add, we do know that there's a positive correlation between COVID and PSA. It's come up 2 or 3 times. I don't know how tenuous it is. Len may remember more on this than I do, but it's been mentioned before, and it's definitely been mentioned in the low intermediate and the AS groups, where they closely follow the small changes and when they're deciding. So yeah, there's some literature on it there, Dr. John.
And what happens? It just goes back down when you recover from
I
COVID?
think so. Yeah. Yeah.
Oh,
Yeah.
okay.
Yeah, and
You get a blip from the COVID, just like Jeremy did.
yeah, and that's what knocked me out of the clinical trial.
Oh,
Yeah, they want
okay.
for the curium, it's copper-based tracer. Again, it follows the actual prostate tissue versus the PSMA. It knocked me out. So, and it's
Okay.
been a recurrent thematic topic that came up. Most of the guys, I think, most of the guys that had brought it up had negative scans, or some of them had negative scans, and it's been brought up. Well, what do you do? Do you wait for the PSA to become higher, so indetectable, and then have to weigh what Len brought up, that one study showed that the success of lower mortality was that the earlier start the radiation, the higher probability of success. And
Have you have you had, or has anybody suggested you consider a Doppler ultrasound to your prostatic fossa?
I brought that up, and both almost both of the physicians, my original surgeon and Percy Lee Radonk at City of Hope, didn't indicate that they thought that was
Yeah.
worthy of doing.
What made you bring that up?
I'm sorry, bring up the ultrasound.
The
I,
high
I
Doppler,
think
the
I
high
think one of
Doppler.
you guys brought it up before.
Oh, oh,
So
really? No, I was
I
just. Well, you're not in San Francisco, are you? Where are you?
no
No, I'm
no
down in Orange County near Newport Beach, Fullerton area.
Well, there's a
right,
fella. There's a fella.
and the guy in Ventura doesn't do it anymore.
Well,
There
there's
are
one
really
guy.
only
There's
two
one
people in the
master.
country.
There's
But
one
Jack,
master
you
at
got
UC. I just
yeah.
wanted to. Let's
Yeah,
finish.
I mean, Shinohara is still great, and UCSF doctors still rely on him doing color Dopplers. There used to be another guy. I think he was a Korean guy, actually, Jeremy. I forget his name now. In Ventura, and people came from all over the United States to visit him. But I think he's retired, and it's very special. But I think, John, I think you got to move on, don't you?
I got to move on. Yeah, we're down to like 3 minutes apiece now. We can go over time if it's okay with Rick. I'm going to skip ahead to Darren because I think he's got to go.
Well, I do have two kids I gotta put to bed soon, but in any case, um, I am going to just recap. I joined for the first time like a month ago, I guess. Diagnosed at 50 years old, 4+3, intraductal, possible seminal vesicle invasion, extracapsular. At the time, I was kind of moving towards surgery pretty quickly with Sloan Kettering and Dr. Ladone. Just doing some research, trying to see if there's any other options out there that may potentially help me post surgery with a better outcome, in terms of maybe less chance for a better cure rate, maybe longer time without recurrence. Um, uh, I was getting interested in PARP inhibitors and how successful they've been because I'm BRCA2, have the BRCA2 mutation, and there was a trial actually that Sloan Kettering was running one of the sites. It's a San Francisco trial, but they were one of the sites, and so I'm in it. I signed the consent form 2 weeks ago. All my scans since then to determine a lack of metastatic have come back clean enough anyway, and so I start the trial on Thursday, which is going to include hormone therapy, ADT, and olaparib for 6 months, and then so 6 cycles of the hormone therapy, daily olaparib twice a day during the period, and then followed by the prostatectomy after the treatment. So hopefully we'll get shrinkage. Hopefully, this is the goal. The tumor moves back into the gland proper, and it becomes a easier operation with a better outcome. Been talking with Rick throughout the process. He's been an immense help. Just one small example, they were going to give me Lupron on Thursday, a 1 month Lupron, and just out of some concern for potential flare, they changed it to Firmagon. So that's going to be my first dose, followed by Lupron for the next dosage. And I'm actually hoping to get Orgovyx for my final dose. We're going to see if that's possible or not, just because the issues of hopefully having a quicker recovery from the therapy. So I mean, right now my question, I'm obviously nervous, apprehensive about how my body's going to respond to the treatment. It feels like a new day, and a scary one at that. But I mean, even the Ember Wave, that was interesting. I never heard of the device. I looked it up. So any other hints or advice or tips for either the PARP or the ADT? I'm all ears. And I know we're on a time deadline, so that's the quick.
We could use some more time to talk to you about that. I hope you come back next week because I don't know if there's anybody in the room here who's been on a PARP inhibitor. There's a lot of people in the room here who have been on ADT, and we can tell you a lot about that. In most of our cases, the adverse effects for ADT start easy and tend to increase over time. So there's no hurry about that. What I personally don't know about is what's the very first week or two on a PARP inhibitor like. Can anybody answer that?
I mean, everybody's different.
Most guys have a lot of fatigue.
Yeah,
I mean, some nausea.
The head, and by the way, everyone at Sloan Kettering has been wonderful, like professional, caring, competent, and responsive. All the things you look for, and so I do feel blessed in that regard to be with the team. Dr. McHugh is the investigator in charge. He's been great, and his head nurse Mary Ellen. So if anyone's in New York, and I mean, I know it's early. We'll see how it goes, but can't recommend them more highly. And they've done this with other patients, and she has, because I come with worries, and she comes with she thinks it's going to be a nuisance, and there could be things that come up, but because of my age, because of relatively good health, she's hopeful that things will be tolerable. So that's
I was apart for 5 days and had terrible nightmares every single night.
Oh,
and
no.
I convinced my oncologist to let me go to darolutamide instead for then, and nightmares stopped immediately. But
wow.
The PARP does cause a number of problems with your blood, but he's young, so maybe they won't be a problem. Your white blood cells, they're a lot of issues.
Yeah. The trial protocol is every month tests. I obviously had to take a lot of tests to get into the trial, the scans that I mentioned, but also all the blood work, and everything is good going in. So we'll see. I mean, that's something. They can't change the medicine in the trial, but they certainly have already indicated that if things are difficult, they'll be able to titrate the dosage down if necessary. So that will be an option.
A couple of things. One is you can pull out of the trial anytime, and I don't know. Hopefully they've told you that. Sometimes they don't like to tell you.
No, they were very upfront. I'm in control.
Okay.
This is not a contract.
If the side effects get too tough, you can stop. You can stop. It might be hard to resume, however, if you felt better, but you can definitely stop, and it's only 6 months.
Yeah.
Secondly, as Jeff Marchi very appropriately pointed out, everybody responds differently. I shared with you, there's a face we haven't seen in the group for a while, Frank Fabish. Fortunately, he's doing okay, but he responded pretty badly to starting the PARP and finished up in the hospital with significant GI issues. And then they took him off the PARP. So we don't know. So, it's a bit unknown.
100%. This whole process is a huge unknown, and like everything that I've learned, every case seems so different. And it's, with my BRCA2, mine obviously has its own unique attributes. So like I said, I'm trying to approach it with positivity, and I have, in some ways, the last month I've been trying to get in better shape, going to physical trainer, trying to getting mental therapy, because there's certainly been challenges there. And
and so don't be surprised also if your mental stability is affected by the loss of testosterone. It happens. It usually doesn't happen right away, but it can happen. Dr. Jeff, you're at the other end of Westchester County to Darren. He's right down by the bridge there into Manhattan, and you're at the top end along with Len. Go ahead. You got your hand up.
Yeah. So the Firmagon, are you getting 2 injections to start?
Yeah.
Okay. So here's caution on that. I let them give me the 2 shots in my abdomen, and it was the most painful 4 days of the last 20 years of my life. I would not recommend getting it in your belly. See if they can give it to you elsewhere. Very, very painful injection. I lasted 4 months on Firmagon, and I said, I give up. You got to help me here. And they switched me to Eligard and now Lupron. But I wish I would have taken Orgovyx, but they told me Firmagon was the way to go. But it is extremely painful, and I think most people would agree with me who've gotten Firmagon.
She mentioned it's going to be uncomfortable. She certainly didn't use that terminology. I don't know if there's any options. I'll bring it up to her in terms of placement, but they mentioned 2 in the abdomen, so it is it is what it is.
It took me a couple months on Firmagon before I had to switch. So
How about
Darren,
starting with Casodex? What's
ask
why
them to
they won't do Casodex?
ask them to give you an ice pack, Darren.
yeah,
Okay. For
Put an
sure. She
ice
did
pack on
mention.
those injections right away.
Jeff Marchi, we've been through it, believe me. And
I'm
the
gonna.
compromise was we'll give him Firmagon for the first shot. They didn't want to give him Casodex, and I said, Darren, you got to insist. And they said, okay, we'll give you Firmagon for a first shot. I mean, to me, you got a T3 guy, and they want to give you a Lupron to begin with, and no buffer. There's something wrong with that. And they said, okay, well, we don't think there'd be a problem, but we will give you Firmagon. So I don't think we should rock the boat anymore trying to get the Casodex. We've been down that road, and we've settled on the Firmagon. Ideally, Orgovyx would be best, but we can't get it.
I still got a few guys, so I'm going to push on.
Go ahead.
Don Rogers.
John, my point is fairly minor, and I'll defer to a later meeting.
You sure you're okay for next week? And also, Steve.
We can, guys. It's fine if we go over. It's fine by me if we go over. If Dr. John has to leave, I can do it. So, if we defer to another meeting, then we get backed up in another meeting. So the more we can handle, the better. The better right now, and we don't have that much left.
Let's go to David.
Go ahead, Don.
Okay. My point. Basically, during my 2 years of ADT, which ended June 1st, I developed osteopenia and was prescribed Prolia. The first
Hmm.
every 6 months. The first shot was fine. The second shot, which I received in June of this year, resulted in, about a month later, tremendous aches throughout my entire body and in the bones in my shoulders and my knees and my hips. Questions I have: is this normal? Uh, that's what my doctors say. It's normal. I mean, my Dr. Belusic and Dr. Crawford, who's a orthopedic oncologist, says this is normal. But this has been going on now for at least 2 months, and it's really significant aches. What should I do?
Who's been on Prolia? Anybody in here on Prolia?
Gary, is your comment about that?
Yes. I'm actually glad to know your doctor told you that was normal. Nobody's been that clear with me, but I'm in that situation and I'm on Prolia every 6 months also.
And are you in pain? Are you getting a lot of pain permanently,
Yes.
Gary?
Yes.
You are.
And it's
Well, let's hold off going to Dr. Jeff because he may have the solution. Is there anybody else? Dennis Correa, are you in the same situation?
Yeah, I'm on Prolia. I've had my second shot. I did not notice any unusual aches or pains.
so I didn't by the time of my second shot, but I've now had, I'm not sure how many, 6 or 7, and I'm having them over the period over the last year, especially the last 6 months.
Okay, Dr. Jeff, let's hear the explanation and what they should do.
Well, don't have pain. I've had 3 Prolia shots for osteoporosis. I had osteoporosis going into the ADT, so I've had 3 shots, and I've had no side effects at all. The doctor did discuss them and said, "Look, you need this, but this is what could happen." I've had zero side effect from Prolia, so I guess I'm very lucky.
Did your doctor mention the body aches?
They did before I got my first shot, um, but I was feeling so bad from the Firmagon and the abiraterone that I couldn't imagine there would be more bad on top of it. Thank God there was none.
That was just the opposite. I was, getting off from ADT. I had stopped abiraterone. I tapered off the prednisone, and that was like toward the end of June, and in mid July, bingo! I woke up one morning. I'm going to tell you, it was significant.
You could
Well,
switch
It
to
is,
Zometa.
it is a known side effect.
Switch to
yeah.
Zometa.
So here's a thought that I have. First of all, you started the Prolia very recently to address the osteopenia. Is that right, Don? After you stopped ADT?
No, I had one shot in December 23. No ill effects at all. Then the
Okay.
second shot 6 months later in June of 24. That's the one that caused me to have the side effects.
Okay. So I think, as Jeff was going to say, there are alternative medicines. And if they're giving them to you at this point in time, since you're no longer on ADT, I'm not sure if they're prophylactic or if they are doing this because you have a problem with osteopenia. But if it's with osteopenia and osteoporosis, maybe you can talk to the doc about resting up since you're not doing ADT. And then when you start again, maybe start on a different medicine. I mean, I was on Zometa, zoledronic acid, during the period that I was on ADT. I didn't have any adverse side effects, and I was on a lesser dose because I didn't have clear bone mets. So I wasn't getting it every 3 months, which is probably what the standard of care is today. When at that time it was every 6 weeks, but it's now probably every 3 months. Second thing is these drugs, whether you're on denosumab or you're on a bisphosphonate, have a very, very long half-life. So they basically stay in your system forever. So you can talk to the doc about also taking it less frequently. In Gary Peters' case, definitely. How long have you been taking it, Gary?
Since spring of 22.
I definitely look to be taking a break for a while. I mean, you just don't need it. They give it because they can, but we don't necessarily think there's good evidence to keep giving it and keep giving it. And, maybe you stop for a while and then you come back on, especially since you haven't been on hormone therapy for a long time. And I mean, this is something to be discussed with a good GU med onc, in my view. Because I don't know who else necessarily has the knowledge, or to talk to a good endocrinologist about it. But they have these protocols in prostate cancer to keep stuffing you with these bone strengtheners, and in principle it's a good idea. But it's like there's a time that you can stop, and then you can get off it for a couple of years, and then you can come back on it.
Doesn't Don have Dr. Belusic?
Yes.
Yeah, talk to Dr. Belusic
Yeah,
about it.
I have,
him
yeah.
about it.
And what does he say?
We talked about trying to get a endocrinologist. Problem is, you ever try to get an appointment with an endocrinologist? University of Miami has 25 on staff. The earliest appointment I could get was next March.
Well, then Belusic will have to decide whether you deserve a holiday or not himself.
Yeah, that's right.
How long after you stopped the prednisone did these symptoms come on?
Good question.
About
Great
a
question.
month. Believe me, I raised that. I am concerned. I was concerned about some sort of adrenal insufficiency, that the adrenal glands weren't producing right. And I ran that by Belusic, and he goes, no, because the classic symptom of renal insufficiency would be low blood pressure, which I didn't have. I monitor my blood pressure every day.
Well, not necessarily. Not necessarily, because what can happen is when you don't have enough cortisone, your ACTH goes up, and that stimulates aldosterone, and aldosterone overproduction actually causes elevated blood pressure with a low potassium. So that's not 100%, it's not even 50% true. But
what blood test do you think I should request?
Well, get your cortisol checked.
Okay. That's what I thought.
Hey, Don, whose decision was it to go on Prolia rather than Fosamax or something else?
That was Belusic.
Oh, that was his first choice?
Yes.
And you only had osteopenia?
Right, exactly.
And he thought you needed to go on it, or you thought you needed to go on it?
Well, there was a discussion about it, and it's standard practice in many prostate cancer clinics, which I'd gone out and talked to people.
I mentioned it to him too because I had osteopenia on my scan in my left hip. I said, "You think I should start the Prolia?" He said, "No, keep exercising."
I have osteopenia all over my body. Whenever
Oh,
do a
okay.
scan, it's read as osteopenia.
Okay.
That
And you
usually in and of itself doesn't get you Prolia, I don't think.
take
Uh,
calcium and vitamin D?
John?
Yes,
Do you take calcium and vitamin D?
yes, every day.
How much calcium, how much D?
I take 1,000 milligrams of calcium, and it's 2,000 milligrams of vitamin D.
Oh, that's plenty.
So
Yeah, it's like
listen, guys, I got 3 guys left, and we're overtime. I feel bad about this. I want to get to you guys, but I don't want to drag everybody into bedtime here. I've got
So,
David. Is David still in the room? David might have left. I've got Dan. Dan, you're still here, right? I
Yes,
see him.
I can be short and sweet.
And I've got Steve. Steve, you're still in the room. Are you guys good for continuing a little longer?
yeah, I'm going to make an executive decision here, John. We'll keep going and we'll get through as many
Yeah.
people as we can, okay?
Okay. Well, I guess David's gone, so let's go to
And no,
Dan.
David is right here. I see David
Oh,
up. He's back in there
Yeah,
right now.
I don't need 'time tonight.
Oh,
okay. Maybe I got the wrong. Was there another David here earlier?
David Muslim was here, but he came in
Oh,
late and he
David.
left.
Oh, okay. Then let's go to Dan.
I just have short and sweet good news. I um, just finished my MRI on the liver. They thought there might have been mets on the liver. It's a false positive, so it's just hormone therapy I've been on, and finished 25 sessions of low dose IMRT. And yesterday I finished the 3 sessions of SBRT, or what they call CyberKnife. They're not going to do a PMSA to test for another couple months. And actually, the best I can say is my PSA has been down from 15 to 10 to 0.52 to 0.2. As of yesterday, it was 0.18. So I think all the indicators are that I'm on a good trajectory when you guys set me on.
Good.
That's
Good.
all I have to report, except for the
Yeah.
side effects. But I don't want to bore everybody with that.
All right. Well, we don't want something growing in the liver, so that's good to hear. Let me just see if I have any questions. They know RP. Oh, wasn't there some argument going on about using a buffer or not for
Yes, and I
for
got my primary to override the oncologist and got the Casodex allowed. And
Okay, great.
that was months ago, so that's old news.
Okay.
So are there any significant side effects that are hard to live with that we can address quickly and maybe give you some tips?
Yeah, they just refused to put any extra brain cells in any of the injections. They just said, "No, Dan, that'll cost you too much money." So
How much money, and can you get a scholarship? I would like to look into that.
no, fortunately, I'm working at home. So when the hot flashes hit, I just take off a shirt or turn the fan on. That seems to be the only side effect I'm going through.
Well, try one of these Ember devices.
All
You're
right.
going to be with them for a while, and they don't work for everybody. They did work for Keith. Um, They didn't work for Harry, which is how Keith came by his. But
Well, Keith,
look, Jeff Marchie's holding his wrist up. See, and
wow.
that somebody else. Oh, Keith's still there. Keith's holding his wrist up. Jeff's holding his wrist up. We used to say this, and there was about half the people in
Yeah.
the room would hold their wrist up and wave it. Look, it's not a guarantee, and I mean they're not cheap, but they're not that expensive. They're around 300, give or take, and for some people they just make a world of difference. They put them on and they would have paid 3,000, never mind 300, because they get a decent night's sleep every night, and it makes a difference. So rather than sort of working home and saying, oh, I just got to take my, well, I tell you, I suffered pretty badly with hot flashes, and they didn't have these embers back in my day. And I see Jeff Marchie smiling there. If anybody suffered badly with hot flashes and couldn't find a result, it was Jeff Marchie. When he first came into the group several years ago, every week he was talking to me, and he'd have this solution and he'd have that solution. He'd be drinking ice water. And now, look, he's smiling. He waves his arm around, his wrist around. He's a happy camper. So try it. EMBR. EMBR. I think somebody will put the link, or I'll try and put the link in the chat window for you, and then you'll come back like as a satisfied customer like Mr. Lawrence.
There you go. All right. Well, thanks for the advice.
It really stops your night flashes, your hot flashes at night.
Oh,
Incredible. Do you have to push a button though? Yes, there's two buttons, one for day
Yeah,
and
is
one
that
for
too
night.
much trouble?
Actually, the my Ember 2 has a sleep setting which goes for 8 hours, which is why I bought a second
Oh,
one, because I would kill the battery, and then the next morning I wouldn't have one to wear. So it does 8 to 10 hours cycle, which is a less smaller cycle, but it made a difference for me. And I'd give you mine, but you're not getting it.
You do is have it to hit always the on? button Is it always just on in as that you're mode then? feeling the hot flash
So
coming on to get the best results. If
yeah,
you hit it too
that's
late,
the hot flash result, and I use that during the day. But at night, I set it for a 9-hour cycle, and it gets me through the night.
what do you mean
I use
by a
7
9-hour cycle?
hours.
What do you mean by a 9-hour cycle? It's always on?
Yeah, so it's always on. It's always cycling for, I think, less frequently and less intensely, but it it worked for me, right? So the hot flash cycle is a 10-minute cycle. You feel it coming on, you hit the button.
Actually,
And
it's a 10, a 5, or a 3. And the night, I use the 7-hour cycle because,
oh
and
yeah,
it does use the full cold strength. But I never sleep more than 6 hours, so I use the 7-hour. But you still have to recharge it. It
yeah,
takes about an hour and a half.
yeah, a couple hours to
But
recharge.
okay,
yeah.
guys, enough Ember. I want to get
Yep.
to Steve. Thank you very much for your patience. What's on your mind? I can't
No,
hear anything.
It's more than one Steve. Is this me again? Or Steve
No,
L?
no,
I think.
it's
Steve
Steve
L.
L.
Okay,
Steve
because
L.
I don't have anything.
Okay,
Steve,
thanks, Steve
we can't
C.
hear you, Steve L. Do you have the right microphone picked out?
Yeah.
Can't hear you. You may have to go out and come back in again, and we'll talk to David Opp, and then we'll come back to you. Go ahead, David. You're muted as well, so unmute.
Yeah, I don't have anything. I'm doing great
Oh, you didn't
this.
have anything. That's
No.
right. That's
Yeah,
right. You
but I'm
didn't have
doing great
anything.
otherwise.
Okay. Well, we better wait a couple of minutes for Steve L to come back. Here he is. Unmute.
No.
No. Can't hear you,
And
man. Sorry.
put something in the chat. Oh, are you on an iPhone?
Yeah, he's on the phone, so
Oh,
I don't
yeah.
know why. We don't know why. You need to call the go-to, Steve, call the go-to, because I think we've had this with you before. Call the go-to helpline and to ask them what's going on when you come in on the phone, and they'll troubleshoot it. It's above our pay grade. All right. Well, are we done? Are we done, Dr. John? We're
Yeah,
only 17
we're
minutes
done.
over.
Steve, just write to us by email if it's a question that shouldn't wait, okay? Hey, good night. Everybody's leaving anyway, so good night, everybody. It's nice to see you all. See you next group.
Thank you, John.
Okay.
Good night, everyone.
Okay. Good
Good
night.
night. Good night.